Hey, everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. Yeah, you're absolutely right. I think we'll see people come in either bagging the patient or an advanced airway, but nothing in between, right? That's okay. I mean, the other thing that I continually bring up is, as that's my thing, is, you know, I think a PEEP valve should be standard practice with a BVM, right? Now, do you need it all the time? No, you don't need it all the time. But in the cases that you do, I think there's two cases. You know, one is you're ventilating the patient and they're still not oxygenating well, then you add the PEEP, right?
Well, explain it to what it is. I think for the lack of
sure. And then the second is if your organization is taking anybody on a ventilator ever, right? And you got to strip the ventilator. The chances are that patient is on some level of PEEP on that ventilator.
I also think they are on PEEP.
Almost exclusively, right? Again, very few cases I've taken that were on ZEEP or no PEEP. They're almost always on PEEP. And if you strip that vent for any reason and then you go to just a bag valve mask, you don't have that end-expiratory pressure keeping the alveoli popped open.
And
right?
so the word literally means positive end-expiratory pressure.
Right. And then that alveoli, and it collapses back down, and it takes progressively more pressure every time you don't leave them expanded. It takes more and more pressure every time to unglue them and pop them back
if you
open.
haven't already gone into atelectasis at that point.
That would be the reason, a reason that we may add it to begin with, right? Is they're failing to oxygenate because of whatever their disease process is, right? So we may add it to begin with. And talk about underutilized, I mean, that's almost non-existent. Yeah. I'm kind of on an island here talking about this because it's in this area, right? And we're talking about Northeast Ohio. One of the things that, I think we're just don't utilize that very simple tool. But
and we don't carry surfactant in the squads.
We don't.
So they do for neonates, I believe. They get it premature, but
they can make it at the hospital. Yeah. They don't have it in the truck.
I don't think people have a visualization of the PEEP. We talk about it right with CPAP. This is what positive end-expiratory pressure is. We talk about it with a BVM. I know we've talked about it on different shows that we've done. A great example of it is an airway class where they just used CPVC or PVC, and then they zip tied essentially pig lungs to it, and they showed you a BVM with PEEP, and then switched and showed you a BVM without it, and that I think gives a lot of people the visualization of the alveoli sac staying open. You see the retention of the positive end-expiratory pressure in the lungs that retains there, so you are ventilating your patient better. But I think it's hard to just kind of visualize it sometimes. And there's, I'm sure there's stuff out there on YouTube and stuff like that.
Every year for the medic class, we get AirMed involved, AirMed, and they come in and we get pig anatomy class.
Yes.
And we do lungs. And actually, Russell Fire Department this coming weekend's doing one. We just got them anatomies. And anybody wants to do that, reach out. We'll set you up with anatomies and equipment, and we'll do the education. But that is so good to see.
I think it drives home the point of it and just kind of solidifies what we're talking about with your PEEP valve and how it should be included in a BVM.
And how much the lungs actually inflate when you're doing proper
ventilation.
And you start really seeing it,
So I'm going to say something that's partially to set you up for the next talking point, but I also want to make the point is, so let's say you had somebody that was on CPAP. He'll take that and run with it in just a second. But
I know where he's going with
that. That's your thing, man.
And they crash.
I'm talking about my thing. You're talking about, But anyway, you got somebody that's on CPAP and they were oxygenating well but getting tired, and you're like, okay, I need to begin ventilating, or watching that CO2 rise on our, we got to ventilate this guy, right?
Well, Scott, you already have a mask in place, and it's hands-free.
I'm going to get, I'll let you get there, and Ray can grab it off the shelf there for you over his shoulder. But the point I wanted to make was, if you were maintaining the SATs on CPAP, right, which is an active process, it's just pushing that air down, continuously pushing that air down and keeping alveoli expanded. Physiologically, you're going to do the same thing with a PEEP valve, right? Except instead of actively pushing pressure down to keep it popped open, you're just going to keep some of the pressure in the circuit when you exhale. So it pops it open, and then it allows you to start to exhale, so you do get gas exchange, but it traps some in the lower airways to still keep that expanded, right? So again, even if you're putting somebody on CPAP and then transitioning to a BVM, you're losing part of the advantage of the CPAP, right?
Correct, with the PEEP, because you have continuous.
Without a PEEP valve, right?
You have it continuously, and then kind of to piggyback off of that point in yours is, if we're going to take this patient that's on a ventilator, we were talking off air even before we started, some of us have areas that we cover with ventilators. So I'm going to take this patient that was a ventilated patient that is on PEEP, and then now I'm going to move them to a BVM without PEEP. So there's a lot of factors going into there that are all BLS skills, knowing how to use your BVM, what's your rate going to be, what's your tidal volume going to be, and then now did I take them from a unit that had PEEP to a unit that does not now. And that's pretty severe. And I think a lot of people overlook that I have this vented patient that's used to getting 375 mLs of tidal volume or 400 mLs of tidal volume.
12 times a minute with a
PEEP
5
of this, 12 times a minute. And then I get up there and we're like, and I'm going to town. It's like, I could actually cause harm to that patient. And I think people overlook it like, oh, no, you can. And it's you can actually do a lot of damage to that patient. You're not ventilating them as well. Yeah, you're making their chest rise, but in theory, you're not really ventilating that patient appropriately because you're lacking the appropriate BLS tools, rate, volume. Like a lot of these things go into it.
Blebs.
Yes, it's a serious concern when you take that long.
Subcutaneous emphysema, tension pneumothoraxes.
Well, and if they have underlying lung diseases, which most of them are going to be, and that's why they're intubated, right? If
Correct.
they have COPD, you couldn't trap air, and that happens with us, that they can just trap air and you're not ventilating anything. You're just, all you're doing is you're pushing air in because the pressure's high, and then you're not giving enough time to have that air come out. And if we continuously bag really fast or push really hard, we're going to just create too much intrathoracic pressure, reduce blood return to the heart, and then maybe pop a blood and cause a tension pneumo. So a PEEP valve will help you with that because it's going to keep the appropriate pressure in there, and you don't. But what I want to say about PEEP though is that you have to keep that mask seal the whole time.
If you're
Absolutely.
Because if you take that seal off, you broke the seal, all that built up pressure inside the lungs, which likely is going to be set at 5 centimeters of
water,
has now come out, and now you have to
rebuild it.
Yeah, correct.
You got to build that. The pressure is always going to be 5, but you're recruiting more alveoli. So the longer the patient has that PEEP, the more alveoli you can recruit. Now, if you let all that air out, the alveoli are going to collapse down.
Gone.
And then your first breath, you're going to get a little of them back. You're going to slowly have to build back up.
Correct.
It's going to take multiple breaths to have that happen.
Yeah, that's a great point, right? If you're using a PEEP valve with somebody's got to basically be that's the case for two. That's the two-handed case. Or
if you've transitioned from CPAP, you can leave the mask in place. It's already sealed, and go right to your BVM. And with PEEP, this works great because you're not breaking seals.
If the head strap's still on there already, right? Then that's a great case, and
Or maybe switching to that is a good option in a low manpower situation of, hey, I could open a circuit just because I just need that mask portion of it because I only have so many providers.
Sure.
So that might be one of your tickets to switch to Caleb's point.
Don't get sidetracked. If this is working, I don't need to intubate per se. I have time. Because the last thing somebody needs chronically who's, COPD, CHF is to be intubated and then spend time with weaning off of a vent.
Yeah,
so
or
if I
getting
can save them
ventilated
this
pneumonia.
way, then
if there are identifiable and correctable things, right?
Sure.
If they're just tired and they've been breathing at 60 times a minute for 3 days.
haven't had nitro to put it somewhere. And
If they're a CHFer, sure. If they're a COPD or the example that you were using, guess what? We can bag them, normalize the CO2, but as soon as we walk away, it's all going to reoccur.
Yeah.
And he's going to wind up intubating anyway, right?
I think that's another great point that I tell all my medics too, is like after you deliver a patient, you give your bedside report, hang around, see what the first thing that they do is, and if it's intubation, that's probably something you should have
done.
considered.
Right.
You might not have the manpower, right? You may not have the ability to, but if that's what the next step is, and you had time, it's something you probably should have done while en route to the hospital.
And we're going to transition here momentarily into the supraglottics. I mean, it doesn't even have to be. It doesn't even have to be delivery of an endotracheal tube, but managing, securing that airway by more aggressive means. Let's just leave it at that for now.
Well,
we'll circle back to that. But.
Yeah, we're talking about non-invasive positive pressure ventilation, which is what CPAP is, BiPAP in the hospital. BVM is the non-invasive. Now we're going to, our next step is invasive, which covers the slew of supraglottic airways, laryngeal mask airways, Kings, and ET tubes.
And ET tubes, yep. IGLs, ET tubes.